All right, here we are, the final explainer in our deep dive into vestibular anatomy. We have traveled from the deepest parts of the temporal bone all the way up to the cortex. And today, this is where it all comes together. We're going to connect those final dots, integrating the autonomic nervous system, which is going to let us put this entire anatomical framework into real clinical action. So let's jump right in. Now, as always, everything we're about to cover synthesizes the incredible detail from that comprehensive clinical review on the anatomy of the vestibular system. Think of this as taking 10 videos worth of knowledge and forging it into one powerful diagnostic tool. And this is the promise we're here to deliver on. You know, we've been building this map piece by piece, and now it's finally time to use it. Time to navigate those really complex clinical presentations with absolute confidence. Because every single symptom has a source. Every syndrome has an address. So let's kick things off with that one piece of the puzzle that honestly explains some of the most distressing symptoms our patients face, that powerful, undeniable link between the vestibular and the autonomic systems. I mean, this is the classic question, isn't it? Your patient comes in and sure, the vertigo is bad, but it's the overwhelming nausea, that feeling of faintness, the cold sweat, that's what's really debilitating. So where does all that systemic stuff come from? Well, the answer lies in a direct, hardwired anatomical connection. And this diagram, this lays out the why perfectly. Look, a sensory mismatch signal, that feeling of something's not right, it hits the vestibular nuclei complex first. But here's the thing, it doesn't just stop at reflexes for the eyes and spine. No, it sends a direct line to this key integration hub called the nucleus tractus solitarius, or NTS. And from there, the signal splits and activates two incredibly powerful pathways. One goes straight to the emetic center, bam, you've got nausea. The other hits the vagus nerve, causing that gut-wrenching distress, maybe even changes in heart rate. This right here, this is the anatomical blueprint for that awful gut feeling. Okay, so the crucial point for us as clinicians is that this anatomy has direct real-world consequences. Take the vestibulo-sympathetic reflex. It's driven by the otoliths, and it helps manage our blood pressure when we stand up. So when it gets impaired after a vestibular loss, well, that's when patients can develop orthostatic intolerance. And we've just seen the motion sickness circuit in action. But what's really key here is this connection explains why vestibular rehab does so much more than just improve balance. By recalibrating the central vestibular system, we can actually help downregulate this maladaptive autonomic output. It all makes sense now. Okay, so with that final autonomic piece locked in, our framework is officially complete. Now for the fun part. It's time to put it to the test. Let's dive into a really high-yield masterclass on using this anatomical knowledge to pinpoint lesions with incredible precision. Yep, this is exactly where theory becomes practice. Let's see how just one anatomical fact can be the absolute key to unlocking a diagnosis. Okay, think of this as your new favorite cheat sheet. Let's just focus on those top two for a second. Wallenberg syndrome from a pica stroke and an ACA infarction. Now, both can cause intense acute vertigo, but the crucial differentiator is hearing. And why? It's pure, simple vascular anatomy. The labyrinthine artery, which feeds the inner ear, almost always branches off the ACA. So, an ACA stroke is likely to cause hearing loss, while a pica stroke spares it. See? One little anatomical detail, two completely different diagnoses. It's that powerful. Now let's look at another really fascinating one, the lambic astasia. We're talking about a tiny lesion in the posterolateral thalamus, the brain's main relay station for all gravitational information. This tiny little spot gets damaged, and suddenly, a patient can't sit or stand at all. But here's the kicker. They have perfectly normal muscle power, perfect coordination. It's not a motor problem at all. It's a perception problem. Their internal sense of what is up has been completely erased. Just incredible. And I really just want to hammer this point home because it's so important clinically. The next time a patient presents with acute vertigo and sudden hearing loss, ACA stroke has got to be at the very top of your list. That auditory clue is your anatomical compass, and it's pointing directly to the vascular territory. This is the power of knowing the map inside and out. So let's zoom out one last time and just recap the entire diagnostic pipeline that we've built together throughout this whole series. We're going from a tiny signal in the periphery all the way to a confident clinical diagnosis. Remember where we started? With the sensors, the labyrinth, and its amazing hair cells. Then, we followed that signal through the relay of the vestibular nerve. We sought arrive at the great integrators, the vestibular nuclei and the cerebellum, where it's all processed. From there, we traced the motor outputs, right? The ones that drive our essential reflexes. And today, we finally connected it all to the systemic interface, the autonomic and cortical pathways that create our conscious perception of the world and our physical response to dizziness. It is a complete, beautiful, integrated system.
So if you take just one thing away from this entire series, please let it be this: a deep, solid understanding of vestibular anatomy. It's not just academic, it's not just for exams, it is your single most powerful diagnostic tool. It allows you to predict, to localize, and to truly understand what your patients are going through. It's not just a map, it's your clinical compass.
Thank you so much for joining us for this series. To explore more topics about dizziness, vertigo, and imbalance, and to get some great clinician and patient resources, please visit AustralianDizzinessClinics.com. And of course, please subscribe and leave a rating.